Hi, this is Tom Inge coming to you again from Cincinnati, Ohio. Thanks for the opportunity to do a screencast this time on bariatric surgery for the very young. I also wanted to thank Dr. Mark Mikowski for offering up some of his work that he previously did in giving a talk about the same topic. I guess that the appropriate subtitle for the talk might be something like, what does common sense tell us, and what do the data tell us? This is a controversial topic, so let's get right into it. I've got no relevant disclosures. A few years ago, September 2013 to be exact, there was a scientific report as well as a report in the lay press about a 2-year-old who underwent sleeve gastrectomy surgery for the morbid obesity that you see here. As you might imagine, this was somewhat upsetting for some and a curiosity for others, and I think those of us who work in the field were quite surprised to see this as well in the literature. I think that the most important take-home message here is that despite the fact that this is a case report in the literature, it doesn't mean that the procedures are justified in 2-year-olds. And I don't think that that's really a question that most people have on their mind. I think that most of us would agree with that. I think that where we do get into more of a question is what happens for those that are just below the guidelines, those that are maybe 12 years of age or 10 years of age. And increasingly we're seeing kids in the 5 to 10-year-old age range appearing in outcome papers looking at sleeve gastrectomy. And so I think that that is the timeliness of this topic. But talking about guidelines, let's just review what are the accepted guidelines in the field that have now dated back really to 2004, but more recently in 2009 and 2012 have been rewritten. We have all agreed that comorbidities or the presence of both obesity and disease should drive decision making around surgery. And whether you draw the line at 35 with severe comorbidities or 40 with less severe comorbidities, most of us agree that comorbidities should be driving these decisions for use of surgery. But also in the guidelines, folks have routinely talked about a concept of developmental maturity. That is Tanner stage 4 or 5, sexual development that goes along with or is a consequence of physiologic maturity. Skeletal maturity with most of their bony epiphyses closed, and the ability to understand dietary and physical changes that are taking place. Importantly, on the psychosocial standpoint, evidence of mature decision-making is necessary because these are operations that require cooperation between the patient, the dietitian, and the surgeon in order to really make the most of the operation and avoid utter failure. Patients need to understand the risks and benefits of surgery because they're actually involved in the decision-making. And in fact, most centers in the U.S. Use an age of 12 or 13 in order to define the starting point for consideration of surgery. So this talk is about the knowns and unknowns. Here we'll briefly go over a few of the unanswered questions. Could there be age-related advantages to operating earlier in life, or are there distinct disadvantages which might say that this is not the right thing to do, that the risks outweigh the benefits of surgery in the pre-adolescent age range? What are the health conditions that should prompt surgery earlier than adolescence? And what weight change can be expected in pre-adolescence? Is it durable from what we see in the literature? And what are the long-term risks of surgery early in life? This is largely speculative, of course. most importantly, again, to address this topic is how young is too young. So Treadwell pulled together a number of papers in the literature back in 2008, and Treadwell showed us that there were a number of nutritional related complications that were being reported even back in 2008, and you can see them here: micronutrient deficiency, protein calorie malnutrition, peripheral neuropathy. We've seen cases of beriberi in our own institution here in Cincinnati, not in quite a while, but in the early days before we began requiring a dedicated thiamine replacement at the time of surgery, and for the first 6 months we've seen this. We've not seen severe malnutrition, although it's been reported, particularly in the very malabsorptive operations. I think we've all seen hair loss, iron deficiency, hypoglycemia, and dumping syndrome, depending on the operation that's used. So all of these items point to a real consideration for the risks of surgery, in particular when it comes to the very young. More recently, we reported from the Teen Lab study problems with iron, problems with transferrin, as well as vitamin A deficiency and vitamin B12. The high transferrin levels are probably just evidence of a physiologic response to reduced iron concentrations in the body. We also realize that these patients that undergo particular gastric bypass will drop their intake from, on average before surgery, 1,600 calories a day. And now this is patients that are in a preparatory phase for surgery, of course. Usually their customary intake is not 1,600 a day. It's probably twice or three times that. But they significantly drop their intake, caloric intake, to approximately 500 or 600 calories per day for the first 3 months, and then gradually at the first year get back up to about 1,000 calories a day. So this is quite significant restriction, and if this is continued, and particularly if you're talking about a 5 or 6 year old that requires energy consumption and fats and protein in order to meet developmental milestones, it could be a problem. In fact, what we saw in addition to caloric restriction after a year was the proportion of fats, protein, and carbohydrates. The proportion of them appeared essentially unchanged from the pre-op, but with markedly reduced total intake. We also saw protein intake, calcium, and fiber intake that were below the dietary recommendations per day. So now just a walk through the literature, and aside from one surgeon in Riyadh, Saudi Arabia, most of the literature is in the form of case reports, essentially just an anecdotal literature. You see here a 10-year-old boy with a body mass index of 42. He had severe pain in his knees from Blount's disease, underwent a sleeve gastrectomy and cholecystectomy without problem. 8 months later, his BMI had dropped from 42 to 28, and his knee pain was gone. No side effects of the operation had been detected. So this surgeon in this group is supposing that a sleeve gastrectomy may be the ideal operation for adolescents with morbid obesity, or in this case, pre-adolescents with morbid obesity. This one out of Trinidad, bariatric surgery and the management of childhood obesity. Should there be an age limit? A 6-year-old girl was suffering from, again, Blount's disease and morbid obesity. She had significant social and functional impairment, and the investigators felt like the case was noteworthy for several reasons, explaining that this was the youngest patient on record who has had this treatment, and that the operation may be a first step procedure requiring a conversion to a Roux-en-Y gastric bypass or BPD, perhaps down the road. I think that this one was one of the reports that caught our eye, and we were asked to write an editorial about it, and I think really roundly criticized the surgeons for really embarking on this treatment. And you can certainly look at the editorial to get a flavor of why. In particular, though, we'll get into most of the reasons toward the conclusion of this talk. Another shown here is the laparoscopic sleeve gastrectomy for the 2.5-year-old morbidly obese child. Now, this is the same report that was picked up by the media, and was a 2.5-year-old with obstructive sleep apnea and leg deformity with a BMI in the 41 range, which declined to 24 by 2 years after surgery. What these authors were also noting was that full compliance could not be ascertained with the preoperative dietary regimen, mainly due to the parents' sociocultural habits. So again, questioning whether surgery should be used in a 2-year-old or whether parents should be intervening in other ways for their 2-year-old who really cannot make any of the food choices. The 2-year-old obviously cannot eat excessively unless those calories are offered to him or her. The only real data in this area comes to us from Ayed Al-Qahtani in Riyadh, Saudi Arabia, where he and his colleagues have made a really good effort to collect objective data, and they have also weathered a fairly extensive criticism for what they have been publishing with respect to surgery in 5-year-olds, 6-year-olds, 7-year-olds, and 8-year-olds, for instance. The aim of this study was to report changes in weight, comorbidities, as well as complications in 3 cohorts, 5 to 8-year-olds, 9 to 12-year-olds, 13 to 16-year-olds, and then comparing them really to an older adolescent and young adult cohort. 3 younger cohorts, and then a control group, if you will. Here's the data from Table 2 in their paper, where you can see that the BMI values in the surgical group in the 5 to 8-year-old range is 43. A non-surgical comparison group of the same age range with BMIs in the 29 were included. A sleeve gastrectomy group in the 9 to 12-year-old, BMI of 45, and a control group that did not undergo surgery in the same age range, BMI of 32, and then the BMI of the 13 to 16-year-olds, 49, the BMI of the 17 to 21-year-olds, 51. What happened to BMI after surgery is shown here, and this is BMI change as measured as kilograms per meter squared, not as percent change, but as drop in kilograms per meter squared. And so what you see is that all of the groups had a dramatic response and ended up with BMI values that were anywhere from 15 to 25 lower than their preoperative BMI values. And this is a 5-year study. Perhaps one of the most important concepts that was shared in this paper is the concept of linear growth change following vertical sleeve gastrectomy in these age groups that most clearly were in a growth phase, that is a linear height growth phase. It's often been challenged that will bariatric surgery interfere with linear growth if offered in these younger age groups that are not yet skeletally mature. And what Ayed is showing us here is comparing the medical versus the surgical groups less than 14 years of age. What they found was essentially that there was no impairment detectable in height change. So this is 5 centimeters of height gain on average in year 1, 8 centimeters of height gain on average in year 2, 10, 12, and 14 in year 5. So their growth was not impaired. They were gaining several centimeters every year postoperatively, and this change in height was essentially non-distinguishable from the change in height that would be expected in patients in those same age groups that were obese, but not morbidly obese, that were not undergoing surgery. They also compared the height gain in those less than 14 to those 15 to 21-year-olds in the study, and they found, in fact, that the height change improvement increase, that is, was greater in the younger age group, statistically significantly greater than in the patients that were older who underwent the same operations and had essentially very similar weight loss results. The youngest children in the 5 to 8-year-old range had the greatest gain in height. They gained 17 centimeters overall. So again, data that are reassuring from the standpoint of linear growth. But height acquisition alone is not really the only thing to worry about, is it? There is certainly reason to believe that a great number of other systems may be affected by surgery early in life. We simply do not know. These are uncharted territories. This has to do with cognition. It has to do with other aspects of learning development, and is really quite a hot topic for research, I think, going forward. Sexual development in girls, where we are expecting a dramatic increase in their rate of growth in the 11 to 12-year-old age range here. That growth spurt that we see pre-adolescent. Still, we don't have really sophisticated analysis of the growth data to tell us what's going on with the limited number of cases that have been reported. Certainly, we worry about hematopoiesis when we are doing operations that impair vitamin B12 absorption and iron absorption and energy absorption. And then there is that concern about bone health and accretion of bone mineral density, which equates to bone strength during these very important years in the first 2 decades of life, really. So operating down here, where bone growth is so phenomenally fast and the bone density increases are supposed to be really quite robust, it really, I think, brings this issue into full focus to say, what are we doing to bone density in these individuals? The fact that they're growing in height does not give us any security to know what the bones are in terms of density. What is the quality of the trabecular versus the cortical architecture? So this is one of the key areas, I think, for ongoing research. So is the physiology of growth and development affected by operating in the very young? Really becomes the broader question. We certainly are aware that there's growth hormone, thyroid hormone, and insulin-like growth factor, as well as insulin, involved in this complex interplay of the endocrinology of somatic growth of the body that includes linear growth and height. We don't know what the effects are of these operations on pituitary function when it comes to young individuals in their 5, 6, 7-year-old age range. As I mentioned, the adequacy of calories is in question based on the studies that have been done. We worry about B vitamins, including B1, B12, these vitamins that have ample impact on our processes of not only hematopoiesis but also neural development, nervous system development, both central nervous system as well as the peripheral nervous system. Calcium and vitamin D intrinsically related to bone health and bone density. And then there's just a plethora of other potential concerns with impacting the micronutrient status of the very young with surgery. Iron intake and iron adequacy from the standpoint of hematopoiesis, but also the standpoint of cognitive development and cognitive learning. Essential amino acids, critical for acquisition of lean body mass. Zinc and copper, which are important cofactors for a large number of enzymatic reactions that occur during cellular metabolism, and certainly adequacy of production and function of bile salts for absorption of appropriate amounts of fat in the diet that include essential fats that we can't actually produce ourselves. So I guess we're getting to the point of talking about a risk analysis. Weight loss surgery in the very young really is, I think, an analysis of risks and benefits. What to do with the patient with disabling Blount's disease, who is 5 years old or 7 years old, or the patient that's 6 years old and has life-threatening obstructive sleep apnea. Again, always a risk and balance relationship, balancing the possible progression of their comorbid disease and significant rise in BMI with development of problems from the surgery. As I've alluded to, there's certainly numerous concerns from the nutritional adequacy standpoint when we are operating during these important developmental age groups. And then there's also another topic that we actually need to address, at least in some ways, and that is the potential impact of ghrelin, which is a hormone that's produced in high concentrations in the stomach, the fundus of the stomach, that's actually removed during sleeve gastrectomy. And ghrelin has a lot of effects within the endocrine system. It's associated with changes in appetite, of course, but also prolactin, adrenocorticotropin hormone, aldosterone, and cortisol production. So one critical question that does emerge is whether the endocrine system of a developing child that is dependent upon normal production of growth hormone and a number of other hormones has the capacity to adapt to a significant and chronic reduction in ghrelin levels following a vertical sleeve gastrectomy. Do we know the developmental importance of early interruption of components of the gut hypothalamic pituitary axis? I think the answer to this question presently is we don't know, and that raises considerable doubts about the appropriateness of elective sleeve gastrectomy in childhood. Again, the importance of the unknown here cannot be overemphasized. So in conclusion, I think that data supporting the use of weight loss surgery in the very young is very limited, at least compared to a robust literature in adults and a growing literature in adolescents. I think we have to consider the potential adverse developmental impact of surgery. It may have a deleterious effect, that is, on a number of critical systems, and when offered at these critical ages could have long-lasting consequences. There's certainly ethical concerns about patient selection that have to be addressed when thinking about surgery in the very young. And there's also consideration that has to be given to parent or caregiver interventions. Have they done everything in their power to get control of the weight and get control of the comorbid conditions in these young individuals? Or does there need to be a case made for state intervention, inpatient treatment, for instance, intensive treatment that might actually result in an improvement in the BMI and might result in an improvement in the ability of parents to manage this later as outpatients? We also have to keep our eye on the fact that surgery is not just surgery. In other words, surgery of today is not surgery of tomorrow. So going forward, are there other therapeutic advances that may be coming that might change the paradigm for what to do with the very young? And I think we've all seen a number of these interventions come and go, initial enthusiasm, and then little effect of the interventions. But I think we do have to keep our eye open to the fact that at least currently resectional surgery like sleeve gastrectomy may well pose a long-term challenge to these patients that device therapy does not. Certainly we all would agree that well-designed and prospective studies are needed, and possibly preclinical studies in laboratory models for learning what does surgery do, how does it impact some of these critical physiologic systems, and are there adaptations that can be prompted to take place to overcome that if we know more about the potential problems. So with that, I'll thank you again for allowing me to deliver this screencast, and again, I wish I was there to take questions, but I know that there are some really good folks there on the panel that would be happy to further this discussion. Thank you very much again.